All right, so next up on the chopping block here is about joint mobilization. And so when you have patients that are going to be a candidate for joint mobilization before even all that, and they're definitely going to be going through an evaluation, examination from the PT, and to see if they would even be a candidate to do the joint mobilization techniques. Some other things, not just the range of motion, but also looking at posture, looking at different accessory motions, strength, everything that would be associated with that. And also looking at different diagnoses, because some diagnoses will have more capsular restrictions. And so if they're automatically diagnosed, let's say with adhesive capsulitis, we already know that that's going to be a joint capsule um, issue, and therefore joint mobilizations are probably going to definitely be implemented. Some different things that you definitely need to review and go back over would be the accessory motions, infills, the convex concave table for the arthrokinematics, and you're going to have to be memorizing and understanding the resting joint positions to know that would be the best open packed position to perform joint mobilizations in. And we'll go through each one in lab anyways of what the techniques are going to be looking, or how the techniques are going to look, and what kind of joint mobs that you can do as a PTA. So some different things that we're going to look at first are going to be definitely definitions. And for joint mobs itself, it's a manual therapy technique. It is used to modulate pain and treat joint impairments that limit range of motion and to address the altered mechanics of the joint. Now, a lot of times mobilization and manipulation can be used interchangeably, but there is a distinct difference between the two because mobilization would be considered a non-thrusting technique while manipulation is a thrusting technique. And as PTAs, we do not do manipulations. And so it's a big hot topic usually with CAPTI, with the whole, ability, is that within the scope? And so just remember that really PTAs are only going to be doing grades 1s and 2s. PTs will show you how to do grade 3s, and you're not allowed to do really 3s, 4s, and 5s unless things change in the future. So, but at this right point, it is not. Like I just mentioned about the differences between mobilization and manipulation, and there's also self-mobilization techniques. That's where the patient can do their own mobilization. There's mobilization with movement that you can do in different joint angles and mobilize the joint. It's also important to know about the osteokinematics of each of the joints. So when we're looking at the accessory components, the component of motion, understanding about what the resting position is, and there's different muscle energy techniques that we'll also go over. But manipulation is a type of mobilization that is under anesthesia that a physician can perform, and that would be usually indicated to where maybe that patient wasn't making any progress with therapy, not improving their range of motion. A lot of times you're going to see that more so with adhesive capsulitis. They'll go in there and do a joint manipulation, or even with, I've seen a lot of total knee replacements to where they improve their range of motion by doing a manipulation too. So it just depends on the situation. I'm not really going to go into the arthrokinematics because each one is going to be totally different. We've talked a lot about arthrokinematics before, and so it's mostly just reviewing all of that information. And we've already talked about axes and planes of motion, so that's all going to be review of the rolling and gliding and spinning in for each one, and about the joint surfaces. So I think you won't have a very hard time trying to figure out each of these, each of the information. So I'm going to keep on going. And from that too, some other things. When you're doing mobilization, you're going to administer it to a long bone, and it doesn't mean that it's always going to be performed parallel or perpendicular to the long axis of the bone. So, for example, because the anteriorly directed angulation of the forearm in relation to the treatment plane of the ulna, our humeral ulnar traction mobilizations are performed in a direction of 45 degrees less flexion than the angle of the forearm. And this is because of the direction perpendicular to the treatment plane. So, like I said, we're going to just be going through each one and seeing exactly what those rolling and gliding and spinning would be for each one. Some other definitions, make for sure that you look over, again, excursion that we mentioned about muscle excursion, but there's also excursion and stress-strain relationship that you're going to see in the stretching lecture, so make sure you look over that information. Okay, all right. But there is, the amount of joint excursion is also listed in some tables in your textbook too. And then the definitions are terms that are listed on this PowerPoint slide. So when we talk about passive angular stretching versus joint glide stretching, so passive angular stretching, that would be rolling without sliding, and that may cause increased pain or joint trauma. And there's a joint gliding stretch, and that replicates normal joint mechanics, and the force is specific to target the tissues. We have some other accessory motions that can affect the joint, such as compression, traction, that would be a longitudinal pull, long axis traction. A distraction is different from traction because it's a separation of the joint surfaces. And so joint traction or joint separation would be under that distraction. So each one of those are going to make a difference in this accessory motion with joint mobilization. So the effects of joint motion will help move the synovial fluid to maintain cartilage health. It also maintains extensibility and tensile strength of articular and periarticular tissues. It provides sensory input for proprioceptive feedback and important for balance response. So especially for that proprioceptive feedback, if you guys remember, all those joint receptors inside the joint for proprioception are so important. So that will help with that. Some indications, if they have pain, muscle gardening, and spasms, if there's that'll help with the pain, like grade 1s will help with pain, and 2. If there's a reversible joint hypomobility, positional faults and subluxations, progressive limitation, functional immobility. So all of these would be indications. Now, limitations of use would be obviously you cannot change the disease process or change inflammatory process. And, obviously how you do it as a therapist will make a big difference if you do it correctly. Contraindications to mobilization or manipulation would be hypermobility, joint effusion, and inflammation. So joint effusion meaning inflammation inside the joint, that would all be contraindicated to perform joint mobs because you'd be altering the healing. So some conditions requiring special precautions because obviously you can do more harm than good. If they have cancer like malignancy, maybe a bone disease, unhealed fracture, hypermobility, total joint replacements, you're not going to do any joint mobs on. Newly formed or weakened connective tissue in elderly individuals. So procedures for applying passive joint techniques. I already mentioned that they're going to go through examination, look at if they have a capsular pattern of restriction, seeing if they have any kind of subluxation or dislocations if they've had that before in the past in the documentation. So now let's get into the grading, right? And you're definitely going to need to know the differences between each of these grades and what they mean. So first we're going to talk about like grade 1s are going to be actually I should say there is a grade 0. In grade 0, there is no motion between the two articulating surfaces, and mobilization manipulation is not indicated because the joint is ankylosed. So that is more so meaning that it's pretty much bone on bone with that bone ankylosing, like as if it is fused, and they're not going to be able to have any joint motion with that. Oh yes, I'm sorry. So there's different grades. Don't get confused like I just did. Now joint excursion is what I just did the grade on. So there's joint excursion grading. and to say implications within the plan of care. Now, when we talk about the joint mobilization technique, that only starts with a grade 1. So grade 1 is a small amplitude at the beginning of range, and it's for pain inhibition and fluid movement. At grade 2 is that large amplitude within the range for pain inhibition and fluid movement. Grade 3 are large amplitude up to the limit into resistance, and that is to help stretch the joint capsule. And grade 4 is small amplitude at the limit into resistance, and that is also stretching the joint capsule. So like I said, for the grades for PTAs, really ideally we're just doing grade 1s and 2s. And I know that there's therapists out there will show you how to do grade 3 and not supposed to do grade 4 or manipulations, it would be grade 5. And here is just a different showing you available joint play. So we'll go over that and what that looks like in lab because it's hard to explain. Let's see. I'm going to keep on going then for each one of those. And those are just comparing of oscillation techniques and joint play. That thrust manipulation is more of going to be especially for grade 5 and high velocity techniques. This is to improve the range of motion. So we would not be doing that. So different applications and how to apply the techniques, it's definitely about positioning and stabilization and doing in the correct direction and the treatment plane that you're going into. And knowing when to be able to progress it a little bit further, maybe from a grade 1 to a grade 2. So all those different things we'll talk about. All right. All right. This is mobilization with movement, MWM. And this is different principles because it's going to be more of a progressive to be able to do joint range of motion in different directions, okay, to help with the gliding and sliding. And it should be with no pain and doing with repetitions. Obviously, looking at the patient's response and progression on how to do that correctly. There's also what's called the Mulligan technique that you can look over what that would look like. Now, each one of these are going to show you, or just that would be for like different joint mobs. We're going to go through the whole body. And here's some, you can look over in your textbook about critical thinking and discussion and laboratory practice. But I did want to make for sure that you look over those grades of joint excursion that's in like the handout that I have provided and know what those different grades would be. Let's see if there's anything else I wanted to mention. So like I said, make for sure that you go over the convex concave rule, look over those charts for arthrokinematics, and all the precautions and contraindications and even the indications for each for that as well. All right. And I think that is all really. The other thing I wanted to mention is called muscle energy. So with that, it's a specific type of mobilization intervention. It uses voluntary contraction of the patient's muscles to move one bone on another. And there's different positions to get this contraction and different muscle groups to work isometrically to have this counter pressure. And with that, it's to help to bring back the joint position. And then that way, you're going to hold for so many different seconds and the patient will be instructed to relax and then the muscle is passively stretched. So there's some different muscle energy techniques that you can be involved to. So there's obviously different indications for that. So I was just reviewing the other PowerPoint handout that I did provide. So just make for sure that you review the definitions of osteokinematic motion, which that is the observable movement of bone in space. So of what you see, remember when you do range of motion and you measure that, you're measuring osteokinematic motion. Arthrokinematic motion is what you feel when you do for like infeels, and that way you can feel what's actually going on in the joint itself of that rolling and gliding and spinning, and that to see what that accessory motion that is taking place. That PowerPoint also has a classification and joint mobility scale of hypo and hyper, so make sure you look over that and know that by term and definition. And just reviewing all of the different terminology that we have talked before, the differences between a resting and closed packed position, and they also have the same amount of grades in there too. There's some oscillations, and those are how many that you do per second. And so there's different things that we'll talk about. And let's see, is there anything else? Yeah, oh, this one is the perfect one. I forgot too. So in that PowerPoint, it tells you what the closed packed and resting position is for each of the joints, or the majority of them that we're going to go over and do. So make sure you look at that. The other thing that I wanted to point out is that you know, the other discussion besides PTAs doing grades 1 and 2s is that they say that we should only be doing peripheral joint motions. Even though out in the real world, you're going to see PTAs do more proximal of, you know, especially like low back or mid back thoracic. You're going to see joint mobilizations for that too, but that's the other hot topic that I just wanted to mention. So that concludes our very quick and short information about joint mobilization. And thank you guys. Have a great day.